Welcome. We're so glad that you can join us tonight. My name is Lydia Dugdale. I'm the director of the Columbia Center for Clinical Medical Ethics. And there are a couple of people I'd like to thank tonight. I'd like to thank the team from Columbia School of Professional Studies for helping to organize tonight's event and running the tech for it. And also to thank Dr. Bob Klitzman, Academic Director of the Masters of Bioethics program, for supporting this effort. This two-part series, of which tonight is the second part, on ethics and opioids, developed out of conversations I had with my colleague, Dr. Barbra Rothschild. Dr. Rothschild is a core faculty member in the School of Professional Studies Master of Bioethics program. Barbra and I were interested in the ethical duty to relieve physical pain in an era when opioid overdose deaths have made us clinicians reticent to prescribe. What is the right thing to do? In seeking to answer this and related questions, we discovered tonight's speaker, Dr. Helena Hansen. Dr. Hansen is a psychiatrist and an anthropologist, and she is currently professor and chair of research theme in translational social science and health equity at UCLA's David Geffen School of Medicine. She's published widely in clinical and social science journals, ranging from JAMA and the New England Journal of Medicine to social science and medicine and medical anthropology. She's published on faith healing of addiction in Puerto Rico. She's published on psychiatric disability under welfare reform, and of course on opioids and race, as well as many other things. She has several books. Her first book is titled Addicted to Christ: Remaking Men in Puerto Rican Pentecostal Drug Ministries. And that came out in 2018. And then she had another book in 2019, Structural Competency in Medicine and Mental Health, a case-based approach to treating the social determinants of health. And her third book is coming out, it's forthcoming with UC Press, and that's titled Whiteout: How Racial Capital Changed the Color of Heroin in America. Tonight's plan is to have Dr. Hansen speak for about 40 to 45 minutes on the theme of ethics and opioids, racial and socioeconomic considerations. And we are going to have her speak to us for about 45 minutes and then ask for questions, which you can put in through the chat function. And we'll take some Q&A for about a half an hour at the end of at the end of Dr. Hansen's remarks. So with that, no further delay, I'd like to turn the podium over to Dr. Hansen. And thank you so much for joining us. We're delighted to have you.
Thank you so much. It's really a pleasure to be with you. Before I start, I want to thank you, Lydia Dugdale and Barbra Rothschild and the Columbia Center for Clinical and Biomedical Ethics for having me. I started off this path of joint training in medicine and social science, actually interested in bioethics. I just want to put that on the table, that was my entry point. And as I went further down that path, I got captivated by the way that anthropologists approach ethical questions, that they really look at ethical dilemmas, such as the ways that we're approaching pain and addiction now in light of the opioid crisis through the lens of the cultural logics that we're operating in and the social systems that express those cultural logics. So I want to hold that up as the lens that I'm going to bring today. And let me pull up my slides on that note. You'll see that I have a very anthropological title for my talk. It's sort of an alternative title in which I'm getting straight to the particular lens that I'm bringing today. It's a lens on race and health from an angle that's unusual in medicine. So that is examining mechanisms of whiteness. So I'm going to share a case study of the hidden but active maintenance of white exclusivity in medicine as a cause of what we often call, quote unquote, health disparities among, quote unquote, underserved minorities. These are groups that typically are described in a passive manner as lacking access to care. But I'm going to outline from my field research and I'll tell you a little bit more about my methods, but from my field research, some more active ways that the at least perceived whiteness of the current opioid crisis has been created. So whiteness is central to our environment of profit motives, commodification, and the use of racial hierarchies to segment and open markets. It involves the mutual racialization of drugs and people, as in drugs can be white, they can target white people, and they can also pharmaceutically enhance the whiteness of people whose privilege is in question because of stigmatizing diagnoses like addiction. I first encountered office-based medication for opioid dependence in the late 1990s. I was a medical student, and at the time I was working with medical school attendings, professors that were running the early clinical trials of buprenorphine, otherwise known as Suboxone. So my attendings at the time, this is a treatment for opioid dependence, and my attendings were excited about buprenorphine, which they said was about to change the culture of medicine. That was their language at the time. By defining addiction as a chronic disease, treatable alongside diabetes, hypertension, and asthma in the same clinics and in the same way with pharmaceutical maintenance. So this caught my ear as an MD PhD student cross-training in cultural anthropology. And I asked myself, what could it mean to change the culture of medicine? What would drive such a change? And as it turns out, my attendings were actually right. So in the course of my career, I saw a profound change in the way that clinicians frame addiction. My field of addiction treatment itself swang from a drug-free philosophy in the early 1990s to opioid maintenance as first-line treatment by the 2000s. And as I completed an addiction fellowship and took a faculty position in psychiatry and anthropology, I also documented stark differences between buprenorphine patients and methadone patients by race and class. So what began as a study of the culture of medicine became a study of how the opioid crisis came to be seen as white, with white ironically at the same time. And this happened ironically at the same time that racially targeted drug war policies led to mass incarceration of Black and Latinx Americans, giving the US the highest incarceration rate in the world. That's what this graph is about. So tonight, I'll give you an analysis from my forthcoming book on opioids and race, which was based on research supported by NIDA, the Robert Wood Johnson Foundation, the American Psychiatric Association, and the New York State Office of Mental Health. I'm going to argue that while narcotics have long been criminalized through association with marginal racial groups, such as turn-of-the-century images of Chinese opium dens, Negro cocaine fiends in the South, and Mexican marijuana madness, we don't often look at how symbolic association with white middle-class markets has legitimated widespread prescription of narcotics. So including, for example, post-World War II epidemic overdose from barbiturates and benzodiazepines that haunted white middle-class America. So that's what's referenced in these ads from the 40s to 50s. So we rarely ask how a drug can assume whiteness in a pharmaceutical logic based on race. And yet this process of pharmaceutical whiteness is at the core of the widely asked question, why is the life expectancy of white people suddenly falling, while the life expectancy of almost every other racial ethnic group is rising? And why and how did overdose become their primary immediate cause of excess death? I want to go beyond the received wisdom that their primary immediate cause, go beyond the received wisdom that unemployed white people in the post-industrial Rust Belt turned to opioids for solace. So that might be true, but it begs the question of why opioids? Why white people, and why now? So I'm going to argue that the current generation of opioids were designed to have white racial identities, and that in our stratified healthcare and justice systems, the social technologies shaping opioid consumption reinforce racial inequalities while at the same time harming white people. And key to this story is an unrecognized form of ethnic marketing that, because it targets white people, works by not marking itself as racial. The story is invisible by design. So it was only through years of observation and interviews with key actors that I've been able to unravel the threads. I've observed drug policy and addiction science meetings clinical interactions over 6 years and interviewed almost 200 addiction scientists, treatment advocates, pharmaceutical executives, policymakers, prescribers, and patients. So let's start where I began this study, which is with buprenorphine, otherwise known as Suboxone, as a treatment for opioid use disorder. And it's easiest to see its racial identity by comparing it to its predecessor, methadone. So here's a bar graph from the first and last nationally representative study to compare buprenorphine patients to methadone patients by race and class. Recent studies have confirmed that buprenorphine is more often prescribed in private markets and white middle class areas. So this is actually some mapping that I did in New York City to establish that. And then this is a more recent study from 2019 that is tracking the fact that this kind of inequality persists. So in this nationally representative sample, white people with opioid use disorder were 3 to 4 times as likely as Black people with opioid use disorder to get buprenorphine. And the most common form of payment in this as of 2015, which is when the study ended, was out-of-pocket payment for a drug that can cost around $300 a month. So that tells you something about the clientele. But what we don't know from graphs like this is by what process did buprenorphine and methadone gain their racial identities? And for that story, we have to go back in time. So let's go back to 1965. Race riots have burned through Harlem, Philadelphia, and Watts, Los Angeles. The unemployment rate for Black people is twice that of white people. Organized crime gains control of Asian heroin imports and recruits a sales force of Black and Latinx people from the inner cities. Meanwhile, Rockefeller University metabolic researcher Vincent Dole, who thinks of heroin addiction as opiate receptor deficiency, analogous to insulin deficiency and diabetes, publishes findings from the first clinical trial of methadone maintenance. So this is 1965 Annals of Internal Medicine. And the study's subjects are African-American heroin injecting men from Harlem. Its outcomes of decreased criminal activity and increased employment at 6 months brings it national attention. By 1970, news of methadone as a pharmacological answer to urban heroin reaches President Nixon, who appoints pioneering methadone psychiatrist Jerome Jaffe as the nation's first drug czar. So Nixon targets inner city Black and Latino people, as well as returning Vietnam veterans, with methadone, the major weapon in his war on drugs. And to prevent diversion and street sale of methadone, the DEA regulates methadone clinics, requiring daily observed dosing and regular urine testing. So due to community resistance to locating methadone clinics in their neighborhoods, the clinics are located in marginalized, disempowered neighborhoods in the city, remote from other medical services. Okay, and so I'm going to now fast forward to 2002, but I'm also going to put on headphones because I think that is my husband in the background teaching music lessons. Okay. So can you hear me? Okay, is that a little better in terms of background noise? Yes, okay, good. So we're going to fast forward to October 8th, 2002. A new kind of opioid problem has developed following Purdue Pharmaceuticals' aggressive marketing of OxyContin as a minimally addictive pain reliever, quote unquote. So most of these newly dependent people are white, and many of them are middle to upper income. The FDA has just approved the synthetic opiate buprenorphine, commercially packaged with naloxone as Suboxone, for maintenance treatment of opiate dependence in buprenorphine certified doctors' offices. Pharmacologically similar to methadone in that it blocks opiate receptors in the brains of addicted patients, buprenorphine can be prescribed monthly for use at home, while methadone is still restricted to DEA-regulated clinics with directly observed dosing. Office-based buprenorphine represents a reversal of national policy. It's the first time since the 1914 Harrison Act that private doctors are permitted to use opioids to treat opiate dependence.
And to accomplish this, the manufacturers of buprenorphine and the architects of buprenorphine policy had to distinguish buprenorphine symbolically and spatially from methadone. Buprenorphine, pharmacologically in the same drug class as methadone, had to be whitened. So this is Mike. He's in an internet ad for Suboxone, seated in his Ohio diner, flanked by American flags. And let's see, yeah, otherwise I might try to play this commercial for you.
Because I think it's a really telling illustration of the race and class imagery that was used.
My name is Mike. Played football in high school, sang in the church choir, classic American upbringing. I used to look at people who used and abused drugs as people who were making a choice. They chose to do that. How could it happen to me? In 1999, we were remodeling our restaurant, and somehow I hurt myself. Our family doctor was on painkillers. Took it as directed. By the time 2004 came, my life was just completely a mess. My body could see me 70, 80, 100 without thinking about it. I felt guilt, I felt shame, I felt dirty. This disease devours your total being. I had to get better. Not just did I find a tool that would work for me, but I found one that would let me continue my life. Being able to visit a doctor like an ordinary patient has made all the difference in the world in my recovery.
So if we take an anthropological approach for a moment and just reflect on the imagery, what this ad says about the intended consumer or patient for buprenorphine. And what it's done to the image of who's an addict, who's addicted. So he's sitting in his own diner, he's a diner owner, flanked by American flags, and talking about returning to coaching his son's baseball team and singing in his church choir after buprenorphine rescued him from a prescription opioid habit following a back injury at work in his diner. This ad is really, the ad is really strongly redefining who is opioid dependent or addicted to be quite an all-American image. It's a very big reversal of the image of who was an addict prior to the 2000s. If you think back to the Negro cocaine fiend newspaper stories that reflected a trope about race and addiction that's carried forward all the way through the crack cocaine era. But I'm going to argue that the reversals in this ad around the racial identity and the class background of who's addicted to opioids was just the tip of the iceberg, that the whiteness of buprenorphine was actively achieved by specific social technologies. And I'll give you an analysis of the contemporary white opioid crisis in terms of what I call technologies of whiteness. So that is social technologies of neuroscientific metaphors, policy, and industry strategies that maintain racial boundaries around biomedical uses of opioids. And this scheme is informed by whiteness studies, which is an offshoot of critical race theory. And it proposes that, one, whiteness is a category of exclusion and therefore requires cultural and political maintenance of its boundaries. So in the US, not anyone who wants to claim to be white can claim it and have it be accepted. It's an exclusive category. So a lot of cultural work has to be put into defining people as white and also places and things such as pharmaceuticals as white. Number two, white race is unmarked as the assumed norm in US society. It's rarely explicitly named either in public policies or in the media. And I would say that over the past 4 years, we've had many exceptions to that. I think that white race has been foregrounded in a way that it hasn't been historically in the country, but it's the exception that proves the rule. So later I'll describe a media content analysis that I did which really demonstrated for me how much it is the case that when race is mentioned in media reports, it's almost without exception a non-white person. And if race is not mentioned, it can be assumed to be a white person. So this also relates to the colorblind ideology that Michelle Alexander, author of The New Jim Crow about mass incarceration, produces inequality by eliminating racial references from racially targeted drug policies and practice. So for example, the 1986 Anti-Drug Abuse Act did not make any mention of racial distinctions between people who use crack and people who use powder cocaine. But that was the legislation that mandated that 1/100th the weight of crack cocaine as opposed to powder cocaine would lead to minimum sentencing. And that was on the heels of a lot of media coverage about the racial distinctiveness of crack cocaine users as opposed to powder cocaine users who were represented as affluent white people. So race doesn't even have to be mentioned in policies to be heavily influenced by racial logics. And then number 3, whiteness is defined by its other. White on the one hand and Black or non-white on the other hand are interdependent. So punitive American drug policy has long had a mutually defining twin of legal narcotics for white people who have had access to personal doctors, starting with morphine and over-the-counter heroin for middle-class Victorian housewives, and then moving to post-World War II barbiturates, stimulant diet pills, and Valium, otherwise known as suburban mother's little helper. Now back to prescription opioid pain relievers. And then lastly, white privilege has its costs. Not only do white consumers pay inflated prices for patented prescription opioids, they also pay with their lives in overdose by lethal substances to which they have quote unquote privileged access. So the 4 technologies of whiteness that I'll be discussing include addiction neuroscience, new biotechnologies, regulation, and marketing. And I'll start with the least visible technology of race making, and that's brain science. So we have to place buprenorphine development on the backdrop of President Bush I's decade of the brain. This was an era in which NIDA was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. In the process, NIDA renamed addiction as a chronic relapsing brain disease, quote unquote. And this was supported by leading NIDA researchers who co-authored this widely cited article in the Journal of the American Medical Association in 2000 at the end of the decade of the brain. In it, they argued that narcotics dependence was comparable to diabetes, hypertension, and asthma in terms of heritability, treatment adherence, and relapse rates. And as such, it should be treated as a chronic medical disease. The scientists involved in this movement had a social justice intent. They wanted to destigmatize addiction by demonstrating that it's a legitimate biological condition, not a problem of morality or choice. What they did not anticipate was that scientific universalism, because it implied a standard white male subject, would help open white markets to new opioids, and that the unequal ways that biotechnologies are disseminated would enhance the social stratification of addiction. So for instance, brain images like this, by taking out the subject and his or her trappings of gender, race, and class out of the picture, and by taking the offending organ, the brain, out of the body altogether, the image symbolically conveys an unmarked universality of addiction physiology. Neuroscientists further reduced causation to molecular action at neuroreceptors, the ultimate disembodiment of addiction. The apparent universality of this molecular model implied an assumed white norm. It took a problem long associated with Black and brown crime and gave it a new implicit association with white people. And in the process, however, it excluded social conditions. So the scientists involved wanted to counteract a drug war mentality by erasing the social context of drug use. Yet they paradoxically set the stage for renewed racial stratification of opioids. So I'm going to go to the next technology of whiteness, which is new biotechnologies. Neuroscientists that I just described unwittingly aided corporate strategies that capitalized on this erasure of the social. Building on neuroscientists' ideology of technological solutions for addiction, in 1996, Purdue Pharmaceuticals got FDA approval for OxyContin as a quote unquote minimally addictive pain reliever, suitable for chronic pain management of moderate pain. And this was based on its patented sustained release capsule technology, which in theory lowered the reward for users by preventing an initial rush. The manufacturer influenced the National Joint Commission on Hospital Accreditation to call for pain to be aggressively monitored and treated as the quote unquote fifth vital sign, along with respiratory rate, heart rate, blood pressure, temperature. And drug reps advised new opioid prescribers to direct OxyContin to quote unquote trustworthy patients as an extra safeguard. So that word trustworthy patients in a national clinical workforce that's been shown to systematically suspect non-white patients of drug abuse implied white patients. Of course, what the model of addiction-proof biotechnology left out was the social inventiveness of drug use. So OxyContin users interested in a rush quickly learned to crush and snort or inject the oxycodone in each capsule. After steep increases in opioid misuse and overdose, public pressure mounted for intervention. And in August 2010, just as the original patent on OxyContin ran out, Purdue Pharmaceuticals introduced its tamper-resistant time-release formulation, embedding oxycodone into polymers that convert tablets into quote-unquote gummies should users attempt to crush and dissolve them in order to inject them. So by keeping prices high and representing OxyContin as technologically sealed off from misuse, the manufacturer strove to keep OxyContin symbolically a step ahead of urban, non-white street markets. Another biotechnology developed specifically in response to the white suburban and rural prescription opioid epidemic was buprenorphine itself, combined with opioid antagonist naloxone and branded Suboxone. Reckitt Benckiser at the time, the pharmaceutical company that manufactured it, promoted this combination of buprenorphine and naloxone as a smart drug. Although buprenorphine is an abusable opioid, the naloxone with which it's combined causes withdrawal symptoms if injected, but not if dissolved under the tongue as prescribed, since naloxone can't be absorbed sublingually. Buprenorphine also posed a lower risk of overdose deaths than other opioids. In the 1990s, NIDA subsidized Suboxone's manufacture with $23 million to test it for use in addiction treatment and sharply distinguished it from methadone, lobbying Congress and the DEA to lower the abuse potential rating of Suboxone from Narcotic Schedule 2, which is where OxyContin and methadone both fall, to Schedule 3, along with codeine cough syrup. And this is what made it possible to prescribe Suboxone in private doctors' offices. The manufacturer also lobbied Congress to get Suboxone included under an orphan drug clause designed to promote pharmaceutical development for unprofitable diseases in low-income countries, such as malaria drugs. Suboxone's designation got it a patent extension through 2009 on a drug initially developed in the late 60s. In a race and class stratified healthcare system, such as we have here in the US, where access to general doctors is often limited to those who can pay, patented expensive technologies for private office delivery in themselves encode white race and middle class. So the third technology of whiteness is regulation. Although by 2004, prescription opioids overtook heroin as the primary opiate of abuse in the US, the arrest rate for their illegal possession was 1/4 that for possession of heroin, and arrests for illegal sale of prescription drugs was less than 1/5 that of arrests for selling heroin. Not coincidentally, the quote unquote non-medical use of pain relievers was twice as high among white people as Black people at the time, while rates of heroin use among Black, Latinx, and white people were almost identical. Since suburban and rural white opioid users were not politically popular targets for drug law enforcement, the DEA and other regulators focused surveillance and enforcement on prescription opioid prescribers and pharmacists instead. So one sign of this has been the spread of prescription drug monitoring programs enacted in 49 states, half of which mandate prescriber participation with threats of loss of license and prosecution. So returning to buprenorphine, otherwise known as Suboxone, the Drug Addiction Treatment Act that was passed by Congress in 2000, DATA 2000, enabled any certified physician to prescribe Suboxone in the privacy of their own offices. And in congressional debates leading to the passage of DATA 2000, there's a clear emphasis on a quote unquote new kind of user, one that's young, suburban, and quote unquote not hardcore. That is implicitly white. Recorded testimony from federal officials stressed that buprenorphine was uniquely appropriate for a new kind of opioid user as opposed to methadone, quote, which tends to concentrate in urban areas and is a poor fit for the suburban spread of narcotic addiction, end of quote. So then Health and Human Services Director Donna Shalala was but one of the many officials who noted that buprenorphine as an alternative to methadone would serve, quote unquote, a new kind of addict, including citizens who would not normally be associated with the term addiction, end of quote. With this racially coded language in which suburban and new kind of addict referred to middle-class white people, DATA 2000 passed Congress and reversed 80 years of federal prohibition of private physician opioid maintenance for opioid dependence. So DATA 2000 kept the restrictive methadone system intact and did nothing to alter the drug laws that mandated inner city heroin users to prison, but it did create a new treatment track for those who had the resources to take advantage of it. To give additional assurance to the DEA that buprenorphine would not spill over into illicit markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, SAMHSA, developed an 8-hour certification course that was required for doctors to prescribe buprenorphine. It's the first and only prescription drug in the US to come with such a requirement. So this was totally unprecedented. Public sector doctors tell me that the certification requirement is a major barrier to making buprenorphine available to low-income people because public clinics do not provide time or incentives to pursue certification, while prescribers in the private sector can charge fees of up to $1,000 for an initial visit for buprenorphine induction. So the shortage of public sector prescribers, along with the cost of buprenorphine itself, have long kept buprenorphine in the private sector. And then the last technology of whiteness is marketing and media. So OxyContin's legendary commercial success hinged on its designation as a quote unquote minimally addictive opioid analgesic. When OxyContin was under review at the FDA, Purdue estimated that the addictive potential of OxyContin, was less than 1%, based on testing among terminally ill cancer patients for a 3-month period. In 1996, the FDA accepted this claim, enabling Purdue Pharmaceuticals to open an opioid market that had previously been restricted to those with severe acute pain, like post-surgical or cancer pain, to a new, much larger market of patients with moderate chronic pain like lower back pain. And Purdue hired almost 700 drug representatives who canvassed a call list of 100,000 physicians in the first few years alone. Purdue targeted generalists in white suburban and rural areas that served patients that the public and the DEA did not think of as at high risk for addiction or as at high risk for drug trade. And Purdue's strategy was successful. It led to a 10-fold increase in prescription opioids nationally, with disproportionate uptake of OxyContin by prescribers in white suburban and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. In a newspaper content analysis that I completed, I found that in contrast to articles about the criminality of Black and Latinx drug users, suburbanites addicted to OxyContin were portrayed sympathetically in the media as victims of overprescription or as people struggling with real or existential pain. Ironically, Purdue's technological response to the first wave of white prescription opioid overdose deaths, their tamper-resistant formulation of oxycodone, combined with new prescription drug monitoring programs, led many of these opioid users to look for heroin when pills became hard to get. And one consequence of this was a whitening of the media coverage of heroin or of heroin users who had long been portrayed as Black or brown. So this is a school teacher from South Carolina, and this is a college athlete from Arizona. And these are just two images from a flurry of media images of the new heroin user. The targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet. Manufacturer-sponsored web-based public service announcements. You just saw Mike's story, which is one of them, which is featured on this website. These announcements featured white professionals and business owners on Suboxone maintenance. And I just invite you to look at this website, which is actually, it's a National Alliance for Advocates of Buprenorphine Treatment. It's sponsored by Reckitt Benckiser Pharmaceuticals, the manufacturer of buprenorphine. And you can see yourselves the race and class coding of the imagined consumer. So if you look at the lower left-hand corner, there's a tab under patients, find a buprenorphine physician. And if you click that tab and enter your zip code, you'll get a printout of buprenorphine certified physicians in your area, the majority of whom will be in private practice. So this is a physician locator service that was created by the manufacturer, Reckitt Benckiser Pharmaceuticals, in collaboration with the Federal Substance Abuse and Mental Health Services Administration. So these strategies together created an exclusive but lucrative segment of the market for Suboxone, making it a blockbuster drug at $1.5 billion in US sales alone per year by 2012. And in that year, it was second only to OxyContin itself, which reported US sales of $3 billion. So this racial segmentation of drug markets into licit and illicit, white and black, clinical and recreational, creates a moving time-bound target of patents on new technologies targeting the white middle class. So this is an old cycle, and it started with Bayer Pharmaceuticals' own heroin, which was marketed as a non-addictive treatment for morphine addiction among middle-class Victorian housewives in 1898, as well as a benefit for these housewives, an extremely effective cough syrup for children. So what can we learn as clinicians, researchers, and policymakers from this story? And first, I'll put on the table that magic bullets are a myth. As the failed promises of OxyContin's sustained release capsule and of the inability of unilateral buprenorphine expansion to, or at least buprenorphine promotions, to stem overdoses has shown, biotechnology cannot stop the harms of narcotics without systemic and social intervention to go along with it. And to underscore this point, I'm going to turn to an international comparison often used by American advocates of buprenorphine expansion. So in France, where buprenorphine was adopted for general physician treatment of opiate dependence in 1995, it was billed not as a stigma-reducing agent for a middle-class market, but as a public health intervention to stem overdose and HIV among low-income, largely immigrant heroin injectors. So buprenorphine in France was widely adopted by primary care doctors in poor communities in a country, and I want to underscore this, in a country with universal health care. So the opioid overdose rate in France dropped 80% in the first 5 years after buprenorphine's approval. And I invite you, so the blue line is overdose deaths and the red line is buprenorphine prescriptions. So contrast this with the US, where opioid overdoses are now 5 times what they were when buprenorphine was approved for office-based use in 2002. And based on my interviews with white and non-white people trying to access buprenorphine and stay on buprenorphine as a maintenance medication, I suggest that the public health potential of buprenorphine is limited by our race and class segregated, market-driven healthcare system, in which patients that have patchy insurance coverage and tenuous access to prescribers have a difficult time staying on maintenance medications to get the benefit, the public health benefit of overdose prevention. Also, France has universal healthcare and a robust social safety net. So these are critical elements to their success with buprenorphine. And I just want to say a little bit more about that. As of the mid-1990s, when buprenorphine was approved in France for office-based use, France funded, the national government funded a network of harm reduction and treatment centers for heroin injectors that provided healthcare and clean syringes free of charge, but also housing, placement, assistance with income and employment. So this was a comprehensive approach that combined harm reduction with treatment and social services, which is not a model that we've had in this country. In this country, because of the historical lack of government support, either financially or through policy for harm reduction services. Harm reduction is usually quite separate from biomedical clinics, and it's usually offered in grassroots or activist organizations that often have to raise their own funding separate from the healthcare system. So it's a very different model. And I also want to make one other point, going back to this graph of overdose deaths and buprenorphine in France. You see in the upper left-hand corner, 565 overdoses in 1995, which was the peak for France. So that's 565 people in a country of 60 million, as opposed to what it might have read here. It's not 565,000 people, it's 565,000. So in essence, France never had an opioid crisis at the proportions that we had. And why is that? Well, it turns out that OxyContin was never marketed in France. Number one, direct-to-prescriber and direct-to-consumer advertising of pharmaceuticals is illegal in France. Many of you may know that the US, for instance, is one of only 2 countries in the entire world that allows direct-to-consumer advertising. New Zealand is the other country. So we're far out on one extreme. But in France, it's quite regulated and restricted how pharmaceuticals can be marketed. And also they have a national review body that assesses new pharmaceuticals for their safety and also for their advantage over existing medications. And that national body either approves or disapproves, and also arranges for national purchasing of drugs. So they determined that OxyContin was essentially not worth the purchase, that it was not a big enough improvement over what was already available in France. So OxyContin simply was not marketed there. And this should be an instructive tale. It should make us skeptical about the power of the market to protect the public and rectify inequalities in health in our for-profit healthcare system. Buprenorphine maintenance has followed the pattern predicted by theorists of fundamental causes who were recently at Columbia, Bruce Link and Joe Phelan. So for many years, they were at Columbia Mailman School of Public Health. They're now at UC Riverside. But according to their theory of the fundamental causes of inequalities in health, new biotechnologies like buprenorphine will widen rather than narrow health inequalities if social drivers of health are not addressed. So in very unequal, socially unequal societies like we have in the US, new biotechnologies will go to the more affluent. And so rather than following the claims of pharmaceutical companies that a new technology is going to solve our problems of social inequalities and health inequalities, in fact, they widen them. And this is the case for buprenorphine in a classical way, but it's also the case for OxyContin, in that people who could afford OxyContin were the ones who got OxyContin. Okay, a second take home is that addiction is biosocial. We should reconsider what it means that addiction is a chronic brain disease. Basic neuroscientists are increasingly seeing the brain as plastic, as a socially responsive organ that has evolved to adapt to complex social systems. And emerging life science models of neuroplasticity, epigenetics, and the microbiome have underscored that human biology is not a fixed entity, but rather it's dynamically shaped in interaction with the environment, the social environment in particular. So these more sophisticated biological models inherently call on us to invest in research on the impact of social systems and on interventions to create healthy social contexts, including robust social services and recovery support networks that give dignity, meaning, and structure to people's lives. If we take seriously the comparison of drug dependence with diabetes, asthma, and hypertension, we'd recognize that each of the other conditions, asthma, diabetes, and hypertension, has strong social determinants, and that success in their treatment and prevention requires, for example, social support, access to fresh foods, safe, unpolluted, walkable neighborhoods, and I could go on. And then a third take home, deaths of despair call for racial and economic justice. So Anne Case and Angus Deaton's 2015 report on the decline in US white life expectancy was unusual in that its authors were not epidemiologists, they were economists. Their analysis of root causes of overdose, as well as suicides and cirrhosis that drove the increased death rate among white people, lay not in neuroreceptors or in genetics, but in the deindustrialization of American Rust Belt towns, where departure of manufacturing and mining industries left behind high unemployment and social disintegration. A sociological study following their report showed overdose death rates were linked to thin social networks. Accordingly, Case and Deaton have popularized the idea that overdoses are quote unquote deaths of despair. So I find their argument persuasive, and it calls for social and economic revitalization through policies that promote social integration, stable employment with livable wages and benefits, and not just public-private partnerships to develop, quickly approve, and disseminate new medications for addiction, as are currently prioritized in the NIH HEAL Initiative and Cures Act. But Case and Deaton's focus on white people makes their analysis incomplete, and it makes Black and Latinx overdose deaths invisible. Case and Deaton don't have a clear explanation of why Black and Latinx life expectancy did not decline in the same time period of their study as that of white people. But I posit that Black and Latinx people saw an overdose crisis themselves 30 to 40 years prior, with the influx of heroin to inner city neighborhoods from the 1960s to 1980s. Blue-collar workers in Black and Latinx neighborhoods were often barred from unions, from labor unions. They were the last hired and first fired, and saw massive unemployment much earlier than their white worker counterparts, who were initially protected by industrial discrimination. So this earlier Black and Latinx opioid crisis was not seen as a health crisis. Rather, it was reported in the popular press as an epidemic of crime, leading to white flight from cities and further disinvestment from Black and Latinx city neighborhoods. So we're left today with the survivors of those earlier crises, even as the CDC reports that Black middle-aged men are now the group with the fastest rising overdose death rate, due in large part to lowered tolerance after mass incarceration and their exposure to fentanyl. So while we work toward race and class justice and economic policy, I argue we should use concern about the current opioid crisis to go beyond drug development, to invest in, number one, universal comprehensive healthcare with psychosocial interventions, including trauma-informed therapy, attention to psychiatric comorbidity, peer navigation, recovery support, and assistance with housing and employment. And two, that we divert people, and that nationally we end criminalization and promote harm reduction and treatment. We divert people with opioid use disorder from the criminal justice system and promote treatment and harm reduction as a national response to opioids, not as local initiatives. And why do I make that distinction? In New York City, for example, we have a program in Staten Island called Project Hope that's diverted over half of those arrested for low-level drug charges from sentencing to treatment, plus matching with a peer navigator. The problem is Project Hope only operates in Staten Island. That's New York City's most affluent and whitest borough. It does not operate in the low-income Black and Latinx South Bronx, for example, which now has the largest number of overdose deaths in the city. And where sentencing continues at high rates, drug law sentencing continues at high rates, and incarceration is itself a risk factor for overdose post-release. So as people are in jail and prison and don't have access to opioids, their tolerance is lowered. And upon release, they encounter, number one, ultra potent synthetic new opioids on the market, such as fentanyl. Very difficult to access healthcare. So for instance, buprenorphine maintenance is very complicated for people who often don't have healthcare upon release and don't have social services and don't have housing. So a lot of stressors contributing to relapse. So it's kind of a perfect storm. But as long as it's up to empowered communities, such as Staten Island, who partnered with their district attorney to start Project Hope, decriminalization and treatment will focus on the most empowered groups. It'll be focused in white middle-class neighborhoods. Okay, and lastly, we have to attend to biosocial and systems research and interventions. So public resources must be moved from drug development of magic bullets to research on and implementation of innovative biosocial community-based treatment approaches. And these approaches include peer-based recovery networks involving the arts, urban gardening, and community-based organizations, including spiritual and religious organizations. These are approaches that necessarily integrate medications with recovery networks of support, harm reduction and social services delivered by trusted community members and peers. With 40 out of 50 US states now reporting increases in overdose deaths since the emergence of COVID, the toxic intersection of opioid use disorder with COVID is making this extremely urgent. So just look at current COVID containment failures in the US based on profit motives, hoarding of tests and supplies, and the feeling among many white people that it's possible to use technologies, including forthcoming vaccinations, to insulate themselves from Black and brown people who've suffered first in the COVID pandemic. So the proactive measures that I just mentioned will move us beyond incarceration and racialized for-profit biomedicine as responses to drugs toward a public health approach that reduces the harm to both whites and non-whites of our racialized drug industries. Thank you. And I hope we can now have a discussion.
Dr. Hansen, that was amazing. Thank you so much. We will move to a period of Q&A now. Dr. Barbra Rothschild and I would invite you to put your questions into the chat. And while you're doing that, I'm going to give a quick shout out to our next event hosted by the Masters of Bioethics program. You can go to their website for more details, but it's December 3rd in the evening. Solutions to COVID Pandemic Panic. Mediation and de-escalation is the theme. So see the website for more details. Please send me your questions. And I'm going to just start, Dr. Hansen, with a clarification from Marcos Fernandez. Now, I think that we have this straight after the rest of your talk, but OxyContin was initially marketed as minimally addictive, but that was a lie, right? We're clear on that. So what did you say? 1% addictive potential is what they were saying?
Those were the initial claims, yeah.
And what can we say about it? 100%? I mean,
there are a number of different reviews with different estimates. One of the most widely cited ones cites 8 to 12% of people on chronic OxyContin management ended up with opioid use disorder of some kind, that met criteria for opioid use disorder, but certainly very different from 1%.
Yes, yes. And I wanted to pick up on some of your last comments about overdose and the COVID pandemic.
Mm-hmm.
Can you give us a sense in our current moment, where are we at? What are the numbers? How bad has it gotten overall in the country? How should we be thinking about it?
So I just quoted a report from the American Medical Association network that 40 out of 50 states are now reporting increases in overdose deaths since the emergence of COVID in March 2020. I can't cite the percentage of increase for all of the states, but many of them are quite substantial, like in the range of 20 to 40% increases. So we're seeing dramatic upticks in overdose death rates. There are lots, it's too early for definitive studies as to why, but there are lots of different factors that could be playing into this. Of course, as you might imagine, COVID containment itself and social distancing have contributed to a lot of relapse and perhaps new use among people who don't have access to the social support networks that they normally would, who might be suffering unemployment. If they are in recovery, don't have the access to treatment or to their recovery groups that they would otherwise have. So, there are all of those stresses at play. And then the tremendous instability in illegal drug markets. So there is a reported increase in ultra potent synthetic opiates in the supplies. And when people have very tenuous access to supplies, they're unlikely to be to feel as though they can discriminate amongst suppliers. There's some really interesting harm reduction oriented projects right now to keep people informed on the ground about supplies and where the really dangerous supplies are coming from. So these are mutual aid groups of people who are using drugs, and harm reduction organizations that are providing services to people who are actively using drugs, and they're tracking feedback on the supplies and posting them on online forums. So there's some efforts to try to counteract that. And then there are policy efforts that I point to outside of the US that I think we should look to, because harm reduction, this is really a big moment for harm reduction. That is something, given the enormity of the crisis facing us. I mean, we already had a tremendous number of overdose deaths at our doorstep prior to COVID, and now it's only going up. So this is an extreme situation. In British Columbia, they've recently passed safe supply measures that enable pharmacists to give pharmaceutical grade medications to people who are dependent on them in the community. And in the US context, that seems completely out of our reach. But I argue that this is a moment of crisis and possibly also for change, and embracing harm reduction measures that other countries have successfully used to lower the death rate pretty dramatically, that we're now being pushed to consider. So for example, what are called safe injection facilities. In this country, probably better to call them overdose prevention facilities. But that's the kind of thing that other countries are now using that we should really be looking to. So this is an enormous crisis. And I also want to mention polydrugs, that the overdoses that we're seeing now often involve not just opioids, but a mixture of other drugs that contribute to the overdose risk.
How are the pharmacists in Canada actually doing this? Would someone with opioid use disorder go in and sort of explain how much they've been taking? Or are they giving them, I mean, I'm just trying to imagine this as a physician myself, how this actually plays out.
So two things. I can't claim a lot of detailed knowledge about how right now people are able to access the pharmaceutical grade supplies. But I understand also that it's not uncomplicated. It's something that is right now in motion, being worked out on the ground. So it's something that is shifting very rapidly as they're testing out different approaches for figuring out how to do this so that it actually ends up being safe supply for people. So there are a lot of logistical questions to be worked out about the safe supply legislation, but I bring it in as an example of a cognitive reorientation that we should consider making in this country, that we can't expect full abstinence. I think the idea of opioid maintenance has certainly taken off for reasons that I tried to outline in my talk. And a lot of it has to do with the power of pharmaceutical industries, that there were financial interests involved in marketing, for example, buprenorphine as something that could be a private office maintenance drug. So we have the power of pharma behind that model. And pharmaceuticals, along with insurance and biotech, make up probably the single largest economic driver in our economy. They have tremendous political power. So they partnered actively with lawmakers to make all of this happen, and unfortunately followed the racial logics that I was outlining. So it's not by accident that we have the widening inequalities that we have from that approach. Harm reduction, on the other hand, has really relied on grassroots activism But I don't want to underestimate that. I'm somebody who was a child of the AIDS epidemic, and I saw the power of AIDS activism to really shift the agenda and to shift medical practice. And that's probably what it will take to make a dent in overdose death rates. We're going to have to have an upswelling of activism, and we as clinical practitioners and researchers should be a big part of that and partner with community-based activists, people who are directly affected by the laws.
There's a question from Jenna Panyajua about what is being done to help those most affected by overdose increases. And maybe I just ask you, so if we think about this current moment, what was it, 2018 or 2019 was the first year we saw a decrease in deaths from overdose, and now it's going back up with the pandemic. We have restrictions on office visits. Some people can't get access, presumably, to their Suboxone or their methadone programs because of the pandemic. Are there new initiatives that we're seeing now? And could you also perhaps comment on things like contingency management or safe injection sites, things like that? Are we seeing an uptick in interest in programs like that? I mean, what's actually happening during the pandemic?
Well, on the one hand, the low-hanging fruit, relatively speaking, has been to provisionally deregulate or make easier access to maintenance on buprenorphine. Methadone also, there are a lot of local regulations allowing for larger supplies of methadone to be dispensed so that people don't have to be on site on a daily basis to access methadone. But most of it is focused on buprenorphine, authorizing, for example, telehealth inductions of buprenorphine, longer periods of refills for buprenorphine. So there's been a lot of focus on that. And I think that has been the low-hanging fruit because it fits into a biomedical logic of, treating things with a concrete medication that's prescribed by a doctor. And all of that is supported by an infrastructure of very, very powerful biotech and pharma companies. Less attention to what you're mentioning, the harm reduction approaches in terms of a national or state agenda. That's where the real struggle is. I've been very impressed by how big a role grassroots, completely underfunded and overworked harm reduction organizations, what they've managed to do creatively and innovatively on the ground. So I co-lead this data collaborative of people who have field data, who are doing observation and interviewing on the ground around the impact of COVID on people who use substances. And time again, what we get is reports of the extreme creativity of harm reduction organizations. I mentioned the safe supply efforts of online reporting and mutual aid around dangerous supplies. There also are safe injection, online safe injection networks now where people are monitoring themselves on screen because they can't do it in person. There are harm reduction organizations in this moment of telehealth where what we're seeing is actually, for some people, better access to healthcare, but for other people, even more inequalities in access because they don't have the right devices for telehealth. What we're seeing is harm reduction organizations that are creating telehealth stations in low-income neighborhoods, in neighborhoods where there are a lot of people without access, so that people can come in and use a device for their visits. So there's a lot of resourcefulness among these grassroots organizations that I think really deserve much more in the way of public support for the work that they do. They're the ones suffering cutbacks right now in the midst of this enormous increase in overdose deaths nationwide. Yet they're the ones with the dedication, the trust of community members and service users, and the nimbleness to be creative about how to respond to what's an evolving scene of COVID.
So that's fantastic. And it's amazing to think about watching one another inject online as a way to sort of hold each other accountable to doing this safely. It's amazing to think how creative and innovative people can become. I want to shift gears just a tiny bit and ask a question that's been on my mind throughout this talk. And that is that there's been a significant rise since 2000 in organs, organ donations
Mm.
from the families of people who have died from drug overdose. And there's a projection that as drug overdose deaths go up, it will increase the organ supply.
Mm.
Another sort of highly, contested terrain in medical ethics, right? And I just wonder from your work, is there ever conversation about that question of organ transplantation and the provision of organs from folks who have overdosed?
Wow, what a fascinating question, and one that I've not gotten before. So this is one of the benefits of talking with bioethicists. I have not run across that conversation at all. And so I'm imagining that there are real patterns to why, I would assume there are family members that are donating the organs, right? Why family members would do that. So often family members are looking for some way of making, of building on the legacy of their family member, and benefiting others from what's a really horrible loss on their part. I would imagine that. I think that if we're talking about affluent people, and I think I've described that we've had these kind of twin tracks of opioid crisis in this country. So middle class to affluent people having one experience and one tier of drug policy available to them, while low-income people, Black and brown people, having another tier of drug policy, which has remained in contrast to the biomedicalized tier of buprenorphine treatment and chronic brain disease, redefinition of addiction as a chronic brain disease. Poor Black and brown people have had another tier which has really continued with punitive drug war, law enforcement. So for that other tier, what the questions it raises for me is, how would those family members look upon it? What would be the issues of trust of the medical system around organ donation? And I believe that historically they have donated less often. And we're building on a legacy where poor Black and brown people have often been the guinea pigs. Teaching hospitals are systematically located in poor neighborhoods because they have provided research subjects for studies in this country. And so there's, a long history of mistrust of the motives of clinical researchers and clinical practitioners. So when it comes to organ donation, I think all of those legacies are bound up in that. And it would be a really fascinating thing to find out to what degree organ donation has even registered as something that's influenced by the opioid or overdose. I should call it overdose crisis, because at this point it's not just opioids, it's actually a mixture of drugs, including stimulants. So the overdose crisis and organ donation is one of the outcomes, a change in organ donations. I think you would see very stark differences in how people perceive that, but I wouldn't know without asking. So you've given me something to ask.
Keep me posted what you find out. I'm very curious. So there are a couple of questions on race specifically. Maybe I'll put them both out to you from Michaela Freeman. In an attempt to mitigate the prescribing volume of opioids as a result of the crisis, how have Black chronic pain patients been negatively affected? And then perhaps a related question regarding racial biases in the marketing. So maybe I should just read that. A large portion of opioid OxyContin crisis started because of pharmaceutical marketing to physicians instead of to consumers directly. Do you think racial biases could have played a role in this, and how? So how we treat pain based on race, and then how we're marketing based on race.
That's a great question. And I think I addressed it in what I was saying, but it was perhaps so quick and so subtle. But definitely pain is raced. Pain is a racialized issue in this country. And you've probably heard the statistics around prescribing of pain medications for white patients as opposed to Black patients. There are classic studies around that have been reproduced in many different ways. For example, children with long bone fracture, if they're white, much more likely to get opioid pain medication than if they're Black. And with based on interviews with prescribers, lots of beliefs around the predisposition of Black and Latinx patients to addiction and the dangers of prescribing to them as opposed to white people. And then there's this implicit, perhaps unconscious, idea of the trustworthy patient. And so that's what I was mentioning with Purdue Pharmaceuticals' marketing of OxyContin, that they did a lot to foreground the safety of OxyContin. Part of that was bound up with the anticipated consumer, that the anticipated consumer was a white middle-class market that was thought already to be at lower risk for addiction. But just to underscore that point, in their drug rep scripts and the way that they trained drug reps to present this to prescribers, they highlighted screening for trustworthy patients. So these are patients that we don't think are at risk for addiction. That translates into white patients in our highly racialized idea of addiction on the one hand and pain, legitimate pain on the other. So there are many, many levels at which the racial identity of pain played into OxyContin marketing and their successes in getting around the regulators. So what I was trying to say, but it also was probably muted and perhaps a little subtle, was that OxyContin got around the regulations for opioids that had been in place for decades in this country, largely because of the anticipated consumer base, that they were thought of as lower risk. And they were in neighborhoods that already were not the target of surveillance for abuse of drugs. That surveillance was focused on Black and brown inner cities. So there are many, many layers at which race was built into this.
One last question. We have 1 minute left, so I'm going to sneak one more in. Abigail Pine wants to know what you think of Oregon's recent decriminalization of drugs, and do you anticipate that affecting overdose rates?
Well, that in itself is a big topic, but I think that the connection between overdose death rates and criminalization of drugs is a strong one empirically, and that in Oregon, they've acted on that. I mentioned the example earlier of British Columbia, where they're focused on safe supplies. So that's another way of decriminalizing drugs in order to lower overdose death rates and the harms of many other health problems that come from being forced into illicit markets, very unpredictable markets, where you can't be sure of the composition of what you're getting, as well as, everything that you encounter, all of the violence that's built into illicit markets, the things that you encounter in trying to get your product. So I think that connection between safety and criminalization is one that was successfully made in Oregon. I think it's a precedent that hopefully will open up other states and other locations in the US to decriminalization. It's going to take different forms in different places. Another thing that I'm interested to see, another connection that I'm interested to see if it's made soon, is the connection between Black Lives Matter and the really heavy, disproportionate law enforcement in Black and Latinx communities and overdose deaths. And the reason I say that is that what we're seeing now is this really rapid uptick in overdose deaths among Black and Latinx Americans. And certainly that's linked to unsafe supplies, among many other things, but they are disproportionately subject to drug law related law enforcement as well, and also mass incarceration. I gave some examples of how mass incarceration in itself is a risk factor for overdose, because people are at such high risk of overdose post-release from jail or prison. So I don't think that connection has really been made strongly yet between the national to international movement for racial justice in policing and in criminal legal systems between that and overdose death rates. But if and when it is made, I think that will give extra impetus. So we can approach this from multiple angles. One is a racial justice angle, and another is simply among white people as well, the impact of criminalization on death rates. So I'm really curious to see if that is another connection that takes off. Certainly, we've seen how far the grassroots activism of Black Lives Matter has gone in putting policing on the map and racial justice on the map.
We will have to have you back in a couple of years for an update then.
Thank you.
Posted. But Dr. Hansen, thank you so much. Barbara and I together, we're so grateful that you came and spoke to us tonight. And we wish you all, thank you for joining us. We wish you all a very good night.
Thank you for your wonderful questions and for having me. Have a good night.